afternoon, everyone. Thanks for hanging around and being patient. I know some of you have to leave halfway through my remarks, so I'm not going to take it personally. Please feel free to step out whenever you need to leave. My session today is called Effective Adoption and Integration of Mobile and Telehealth Programs. That's a long session title, and I'm not going to talk about that. I will, but let me just clarify what I'm going to talk about. By way of full disclosure, I should tell you a little bit about my background so you know how to situate and contextualize my presentation today. I have a background in mathematics, in computer science, and information systems and business. You'll notice that an MD is not part of my earned medical degrees, but in the course of working with health information technology over the last decade or so, I've learned enough medicine to be dangerous. What I have studied extensively in my academic career over 25 years is how to infuse technology successfully into different kinds of settings, both organizations as well as into individuals' hands so that they can be productive users. So a lot of what I'm going to be talking about today comes from that perspective, and that perspective was succinctly summarized by Jay this morning when he said, don't overlook the importance of resistance to change, right? So what we're fundamentally talking about when we look at all these disruptive technologies and how we think they can transform the healthcare system, the question that we need to address before any kind of technology design or before any kind of technology rollout is how do we overcome that resistance to change. Jay also told me this morning that I'm not smiling enough. So I changed my presentation at the last minute to start with this cartoon, which I think is going to make us all smile. This is from last week's New Yorker, which says, you can't list your iPhone as your primary possession. And I think that nicely summarizes why we're all here, because we're all here because in some ways we are believers in technology evangelists, right? We believe that health information technology and mobile and telehealth technologies, just being one manifestation of health IT, can make a difference. So what I'm going to talk about in the next 30 minutes or so are three major points. I'm going to take us to a 30,000-foot level and argue that all of these technologies that we're talking about are fundamentally innovations. And in order to understand how to accelerate the adoption and diffusion process, we need to understand something about the nature of innovations. And we need to understand what decades of research that has studied innovations tells us about the nature of these diffusion processes. I'll discuss the different stages associated with innovation, adoption, and diffusion, pointing out that there are many obstacles along the way, and our strategies ought to be designed to address those obstacles as we move along. And then based on my own research as well as decades of published research by scholars and researchers from multiple disciplines who've been studying technology innovations, I'm going to present some simple, proven strategies for effective adoption and diffusion. And the nice thing to note over here is that this is not rocket science. Okay, this is not rocket science. It's something that addresses sort of the social, the economic, the behavioral, and organizational challenges that we need to overcome. Intuitively, we all know and we all understand them. Where the rubber hits the road is what kinds of tactics can we use in a setting that's characterized by centuries-old practices? What kinds of tactics can we use when our target populations are individuals who've been doing things a certain way for many, many years, where our target population, and I'm talking about providers here, is individuals who have mental models about how work gets done or how medicine gets practiced. So we'll discuss some proven strategies, and then I'll spend a few minutes on the future. So let me get started by saying a few words about the nature of innovations. Sometimes when we think about innovations, the first thing that pops into mind is invention, right? That something completely new coming into the environment or the ecosystem. But that's not the kind of innovation that we're talking about here. What we're talking about really with mobile technologies as well as telehealth technologies is that the idea, artifact, or practice is perceived as new by the adopting unit. Okay. In other words, it might be a very simple innovation such as a smartphone that's been out for a very long time, but as long as our target population of adopters and users thinks it's something new, thinks it's something different from the way they do things, it's going to disrupt their work. It's going to disrupt their lives, and that's why we need to manage and orchestrate the process carefully. Now, when we think about innovation, there are lots of adjectives, if you will, that come to mind. Creativity, discovery, invention, and by invention here I mean that a lot of new ideas about how to use gadgets, about how to be more productive with new technologies, come not from the developers, but rather from the users, from people who take these tools and then assimilate them and incorporate them into their routines in so many distinctive ways, in so many interesting ways, that we as developers or we as technology implementers really discover new ways in which the technology can be used. The common theme across all of this is novelty, right? It's different, it's new, it's unique. And the creation of value only occurs after adoption and use. Not through just development, but after adoption and use. You know, we have a term in academia that we call shelfware, and sometimes people in practice use it as well, right? And that's, you know, what do you have in the last drawer of your desk? A bunch of gadgets that you acquired and are probably never going to use. And even tools like Microsoft Office that are so widely dispersed in industry, if you go out and look at how much of the functionality of those tools is actually used, it's less than 30%. Okay? So where adoption in and of itself is valueless, what we really want to focus on is extensive, detailed, and value-adding use. Okay, so technology innovations have had a checkered history. Here's an example. You know, even when wheels were first discovered, there were lots and lots of people who believed that this was not a technology that was going to rock the world. And the story is no different in the context of mobile and telehealth technologies. This morning we've heard lots of discussion on how robust this market is. So, you know, I'm not going to read the statistics over there, but there's a lot of money going into mobile health. There's a lot of investor interest. The bad news is that there are lots and lots of apps out there, but nobody's using them, right? And even when people are using them, they're only doing so for very short periods of time. As soon as the novelty wears off, the app is being abandoned, right? So we are witnessing adoption, if you want to count adoption as the number of downloads that took place, but we're not witnessing any kind of use. And perhaps that's one of the reasons, as Kenan pointed out in his presentation, that we don't have enough research that documents value, because, to be candid, we don't have enough people out there who are actually using this stuff on a sustained and long basis. And the news is the same for telemedicine. I'll just quote from an academic article published by one of my colleagues last year. Telemedicine is plagued by hazy economic cost and revenue measures, which are complicated by insurance reimbursement challenges. And I think we've discussed each one of these today in different presentations. So how has the research community responded to this emerging new technology and its adoption and use challenges? Well, the good news is that researchers are active, and my center just completed, under the guidance of Gordon, one of our PhD students, finished a systematic review of the mHealth literature. We started with 6,218 articles, and finally narrowed that down to about 83 articles that specifically addressed issues related to adoption and use. And here's what the summary of the articles showed. And we've discussed many of these before, so I won't dwell on them too much, except to point out that there are a few additional distinctive barriers here that I feel have not been discussed yet. Organizational barriers. John alluded to these a little bit in his talk this morning. You know, organizational barriers refers to the signals that you get from leaders within the organization, right? The commitment of top management. John, you spoke about you know, the dean of the School of Medicine just barely coming around to understanding what telemedicine means. The fact that your CIO does not fully comprehend the value of telemedicine or what these technologies can do. So physicians are not immune to these disconnects between what the technology evangelists are trying to do and what the top management feels is the right way for the right direction for the organization to proceed. So these organizational barriers are salient in physicians' minds, and they step back and they say, hey, I'm going to wait this out and see what happens when I get the right signals from senior management. I'm going to start moving. Barriers to patient adoption, we've discussed many of these. Let me just underscore the usability barrier. And I heard an interesting quote from a patient who said, I don't know who designs the software, but clearly they've never been sick. I heard a very interesting quote from a physician who said, I don't know who designs the software, but I don't think they've ever practiced medicine.
Right.
Okay? So the point is, I mean, you all know, you work with this stuff. The electronic health record systems are a nightmare. You know, even usability 101 that we teach our undergraduate students, they would not pass the test of usability 101. So clearly, if we want widespread adoption and we want the masses to start using these technologies, we have to do something about usability. Okay, so that's what our systematic review of the literature showed us. And it also pointed out some other adoption challenges. I think we've talked about each one of these. Let me underscore what I believe to be two critical issues for mobile health that we haven't addressed fully yet. Multiplicity of devices. You know, we are in a BYOD world, and when you start moving apps across devices, you run into all kinds of unanticipated problems about look and feel, right? Whether the size of the screen is large enough to show the data in an effective manner. You start worrying about integration across different operating systems and platforms. And then you start thinking about, well, how do I take all this data, which is invaluable, this data that patients are creating or this data that is being generated through patient-physician interactions, and how do I integrate it with my existing administrative and clinical apps? And again, John alluded to this a little bit, but until we have the right kinds of connectors in place, until we can fully connect the dots all the way from roaming devices, mobile devices, virtual consultation, whatever you want to call it, to the actual box that sits in the hospital, or the box that sits out there virtually in the cloud, I don't think we're going to get to effective medicine, as Jay pointed out this morning. And then the uncertain and the unquantified efficacy. My economist friends and researchers in behavioral economics will tell you that every individual is trying to maximize their expected utility, right? Expected utility means I'm going to do something only if it creates value for me. Until we have a compelling proposition or a compelling story to tell about how is this app on your smartphone going to help you get better, how is it going to be more convenient for you, how is it going to help you overcome your inability to breathe if you're a COPD sufferer, whatever medical condition you might be managing, unless we can present the evidence that this app or this intervention is going to help you, we're not going to see that transition from just passing interest to becoming a sustained user. So this is a complex conundrum of policy, technology, design, organizational, social, and behavioral factors. So my talk is on organizational, behavioral, and social factors. When I present the strategies, that's the perspective that I'm taking. I think we heard the policy piece a little bit at lunchtime, and we'll hear more about it at dinner time. And then the technology design piece, we could spend an entire day talking about it. But I think Albert is going to address that a little bit in some of his remarks. Okay, so let's get to diffusing telehealth and mobile health. And, I'll just call it digital medicine to not have to say the whole thing throughout. The good news is that these technologies are not unique, right? That's the reality. It takes time for any technology to diffuse to a population. And if you look at this chart, it shows you the number of years it took for major technologies to reach 50% of homes. Obviously, some technologies have diffused much faster than others. Unsurprisingly, cell phones are up there, MP3 players are up there, DVD players are up there, telephones took a long time, right? Took a long time. Can anybody tell me why?
Open lines?
Interoperability.
Actually, something called network effects, right? So telephones are subject to network effects. That is, the value to me is a function of the number of other users who are using telephones as well, right? If you think about MP3 players, DVD players, digital TVs, and internet access, these are not technologies that are subject to network effects. So the takeaway here is that if you want to truly diffuse technologies very rapidly through a population of adopters, what you need to set in motion are these network effects, right? Which says the value to me personally rises, and that's what the two-sided platforms do. The value to me personally rises at the moment there is another user, another marginal user of the technology. All right. So innovation diffusion in populations follows predictable patterns. Some of you may have seen this chart before. Please raise your hands if you have. Okay. So this is Rogers' model of the diffusion of innovations. It's probably the most influential and widely used model. It's been applied to diffusion of innovations across all kinds of sectors, from agriculture to healthcare to financial services, to you name it. And fundamentally what this model says is that in any population, you're going to see a classic bell curve of adopters. You have a very small number of individuals or entities who are the innovators, and then you have the early adopters. So together these are about 15% of the population. And then in the middle over here you have this large majority, of which about half are the early majority and a second half are the late majority. And then down here you have your problem children, right, the laggards. Those who will not get onto the technology bandwagon for a very long period of time. So what does this model show us? It shows us that certainly not everybody is going to adopt at the same point in time. It also gives us some tools that we can use to craft strategy as we think about adoption and diffusion. And what we want to try and avoid in our adoption and diffusion strategies is what's called the diffusion chasm, right? And here what the chasm means is that there are many innovations, and digital technologies in health, digital medicine, might well be one of those technologies, or some parts of it, where after the innovators and early adopters have quickly gotten onto the technology bandwagon and said, this is cool, I want to use it, I'm going to try it, I'm going to play with it, I'm going to experiment with it, then the technology crashes and burns, right? It falls through the cracks and you never get to the stage of full adoption. Also, what this model tells us is that we really don't want to try and convince the mass about a new idea. We want to try and leverage the innovators and early adopters first, because those are the people who are going to be our evangelists or our change agents, if you will. And again, John this morning talked about opinion leaders, and I'll come back to that in a little bit. So let's look now at the individual adoption cycle, right? What I shared with you was how innovations diffuse through populations, but it's also very useful for us, and in fact, this is where our strategy formulation should go. That is to look at the individual adoption cycle across mobile and telehealth technologies. Individuals go through 5 very distinct phases as they make the decision whether to accept or reject new technologies. The first phase, or the knowledge phase, the question that's foremost in everybody's mind is, what is it? Right? What is this gadget? How do I know that this innovation has entered the environment or the ecosystem? For example, some of the cool things that Kenyon described in his presentation, right? The wearable t-shirts, the sweaters, I've even forgotten. He had all kinds of cool stuff in there, right? Now, for many people in this room, it might well have been the case that was the first time you heard about it, right? So the question in your mind was, what is it, right? What is it? Once you know what it is, the next stage is called the persuasion stage. And here the question in your mind is, why should I use it? Right? Why should I spend the time, the effort, the cost, the cognitive burden to acquire this technology and begin to use it? Once you have these 2 questions answered, you reach a fork. And this is a crucial fork, right? That's the point where you say, all right, I'm convinced, or you say, forget about it. I'm not going to touch this technology, right? So let's assume that our potential adopters have said, all right, I'm convinced, and they haven't fallen out into the rejection phase. Then you get into the complex question of, how can I be productive with it? I've made the decision to adopt it, but now, how can I integrate it with my activities of daily living? How can I integrate it with my clinical workflows? Or whatever practice, whatever activity I'm engaged with, where does this disruption, where does this intervention fit in with what I do? And that's a difficult question, and that's one that has to be proactively managed and strategized for. And then finally, you get to the routinization stage, which is, how do I freeze the change, right? I've learned a new behavior, I've figured out how to use the technology, I've figured out how can I be productive with it, now how do I make it a habit, right? So our goal in all of this is to make technology use a habit where you couldn't envision doing your work without it. Very much as you couldn't envision today not having a cell phone. And I always joke that 15 years ago, I made a remark to my spouse saying, why in the world would anybody need a cell phone? Okay, and at that time, I was, actually it was more than 15 years ago, I've been at Maryland 16 years. So at that time I was a professor at Florida State University in Tallahassee. I don't know if anybody's been to Tallahassee, but it's a small town. And it takes you only 15 minutes to get from one part of town to the other. So you figure, why do you need a cell phone, right? I mean, I can get from here to there in no time at all. And then I arrived in Washington, and I sat in the Beltway for many hours in a day, and then I said, yes, you do need a cell phone. Anyway, so freezing the change is an important aspect of the individual adoption cycle. And now I'm going to walk you through some specific strategies that can be used to overcome the barriers and questions that people have in each one of these stages. Okay, first, what does this model tell us, and what's the insight or takeaway that we should be cognizant of? Adoption is a means to an end, and it's not the end point. So let's not forget that we can't pat ourselves on the back by saying, okay, 60% of our population has adopted, because that doesn't mean anything, right? It is just a means to an end. You might argue that usage is an important outcome, that people are using this extensively. I've got 30% of my providers who are using telehealth for 80% of the consultations that they need to do. All well and good. But that's still not enough. Our ultimate goal should be to get towards what we call extended, enhanced, emergent, and routinized use. So let me just explain what extended, enhanced, and emergent use is. I commented earlier that there's an element of invention even with innovations, right? And I am continually struck when I go out and work with healthcare organizations to see the types of workarounds that doctors develop, to see the type of workarounds that patients develop, to learn something new and creative and interesting to do with the technology. And that's what emergent use is, that's what extended use is, that's what enhanced use is. And at the end of the day, that's what's going to create value from all these gadgets and tools for digital medicine. So that's what our goal should be. Okay, so moving right along. We start with the knowledge phase where, as I pointed out, the question is, well, what exactly is this gadget? And studies suggest, Rogers' work suggests, that information about the existence of a disruption or an innovation is acquired through two major communication channels, mass media and interpersonal channels. So as implementers, our objective should be to manage the media hype. We know that socioeconomic and demographic characteristics affect the types of mass media that people pay attention to. So for example, we've heard a lot about how telemedicine has significant value in rural areas just because access to physicians is much more limited in those areas and physician density is scarce. Well, we also know that in rural areas, people get a lot of their information from TV. They don't get it from the type of media channels that you and I might be listening to or reading in the Washington, D.C. area. So we need to understand what the socioeconomic and demographic characteristics are for our target population of adopters. We need to understand what are the mass media channels that they're paying attention to, and what types of information or messages about these inventions and these innovations is being conveyed to them. I think you would be surprised if you actually went out and did a study in rural Maryland to find out how many people know and understand telehealth, or what their mental models are about these innovations, because often what they hear through the media is, to you and I, complete gibberish. It's a complete, what I would say, misrepresentation of the nature of the technology as well as what it's designed to do. So the point here is quite simple, that we need to the extent possible, actively manage the channels through which information about the invention is disseminated to our target populations. And we also know from lots and lots of research that word of mouth is the most powerful agent of change. So the simple tactic here is send somebody out there, right? There's nothing like boots on the ground to educate people in rural areas about the value of telehealth, to have these little town hall meetings, whatever mechanism you want to use, where knowledge about the initial entry of the innovation, even before it comes into the market, is being made by somebody, or is being created and communicated by somebody who fully understands the nuances of the technology, and who is not simply hyping it up because of vendor pressure or political pressure or whatever the case might be. All right, so once people know about the existence of the innovation and you've managed to make sure that they've got the right information from word of mouth as opposed to just the media hype, the second stage is persuasion, right? And here's where you're trying to quote-unquote sell the technology, right? You're trying to market it. And I heard this morning somebody make the comment about, well, at the end of the day, this is marketing, right? This is marketing. Yes, it is marketing. It's also social marketing, because we're trying to sell people something that's we think is going to be good for them. So how do we manage the message? The research shows, again, across a wide range of innovations, but particularly in the case of health information technology innovations, that there are attributes of the innovation that influence people's mental models about the innovation. And the three most critical attributes across any type of digital technology you want to think about are relative advantage, how is this better than my previous ways of doing the same thing, complexity, or the flip side of it, the ease of use, and compatibility with my workflow and with my values. And this is critical for telehealth, right? So think about this. A doctor who is sworn to the Hippocratic Oath and who says thou shalt do no harm, if he or she believes that telemedicine is not as effective as a face-to-face consultation, and that they might miss some signals from their patient, which are critical for high-quality patient care, whatever you tell them, they're not going to be evangelists of telehealth. They're not going to come to the table willingly, and they're not going to come wanting to embrace the technology. So relative advantage, complexity, compatibility, and then in the context of mobile and telehealth technology specifically, also privacy and security. So the first tactic to use here is to manage the message, and the second one is to co-opt champions, as John talked about earlier. So let me say a few words about how you might craft the message for relative advantage. What I have on this slide is a quick summary of why is this good to me? Why is this good for me? Why should I use it? For both providers and for patients. And we can scour the literature and identify lots and lots of different reasons why this should be good for providers and this should be good for patients. And what we need to do is to kind of package this into a compelling story and present that to the adopting population or our target users. Champions. Champions are your friends, right? We know that champions will intensify the rate of adoption. So we want to wine them and dine them and keep them happy. We want to engage them. We want them to be those who market and sell the technology to the adopters. We don't want the technologists to do that, because study after study shows that anybody who has an IT background, including myself, is generally not a very good salesperson. And not a very good salesperson to those whose work is being disrupted by the technology. Right? Again, at the risk of creating a sort of a stereotypical characterization, we know that there is a communication chasm sometimes between IT professionals and users, right? Because of different language, different backgrounds, etc., etc. So in the healthcare setting, the opinion leader must be a respected professional and preferably a clinician. And John showed us this morning the opinion leaders in the context of your telehealth implementation, right? And you had a physician and who else?
Physician, non-physician, clinical, and administrative.
Yeah. And here are some other attributes of this champion. An outstanding communicator, somebody who's personally innovative, and when I say personally innovative, I take you back to the adoption curve, and this person, he or she, would fall into the innovator category, the 2.5% of the population who will jump onto the technology and embrace it.
I would also say commitment. Commitment.
Absolutely, yeah. Commitment to the cause.
Right.
Yeah. I think I sort of assumed that the signal of commitment was in the fact that they were the early adopters, but you're absolutely right. Commitment to the cause. You need a technology evangelist who truly believes that this will be transformational in some ways. Okay, the decision and learning stages, the critical question is, how can I be productive with it? And here, the sustaining environment for technology implementation, for technology rollout plays a critical role in addressing this barrier or hurdle to adoption. And we've heard about these points earlier on, but I think it's worth summarizing them in one place. There are two key tactics here, training and support and admin time. I think training and support everybody understands, but admin time is perhaps a little bit different, so let me get to those. So what do we know about training and support? There are many best practices in use today. We want training to be just in time. We don't want to train somebody and have them use telehealth 6 months from now, or show a user how to use a mobile app and then not make it live for another 4 months. It has to be relevant and customized, and it has to address the multiple learning modalities that people have, right? So if you have visual learners, if you have audio learners, if people like to learn in groups, so they like to learn individually, pedagogical delivery is something that we feel very passionately about, and we're continually experimenting with new ways to offer instruction. And I think sometimes when I look at the design of digital technology rollout programs in hospital settings or other kinds of places, I'm amazed at how non-creative some of these training approaches are. So I think those who are responsible for designing training for these systems really need to learn some best practices from industries that have been doing them for decades. Perhaps the education industry is not the best, but maybe you can turn to some professional training institutes instead. And then you want to offer training that's in multiple varieties, because fundamentally any new technology is about the user being in control, right? And if you cannot, if the training cannot give users that sense of efficacy and control over what it is that they're trying to do, they're just going to walk away from it, right? And especially in a time-critical setting like healthcare, if it doesn't work like this, I don't want to have anything to do with it. And training has a big role to play in overcoming that hurdle. Okay, support structures, help desk, tips and tricks, on-hand supports. One technique that we found to be very effective, again, in healthcare settings are user groups. We also call them communities of practice. And these are fundamentally small groups of early adopters and innovators that you bring together as a way of collating, if you will, all the organizational knowledge about that new technology, right? So this group shares experiences in a rich face-to-face informal setting, and then documents those experiences for wider dissemination and for wider leverage throughout the organization. So these user groups and communities of practice have been used very successfully in a number of industries and now are being applied in healthcare settings as well. Okay, so let me turn to admin time. We discussed technology leaders like Google. Let me present to you another leader that we don't think of generally when we think of high tech, but a leader nonetheless, an innovator, 3M. What can 3M and Google teach us? Well, in every contract that 3M and Google sign with their employees, 15% of their time is devoted to innovation. Right? Now, whether I spend 15% of my time on innovation or not is a different matter altogether. The point here is that there's a very strong signal, there's a very strong message coming from senior management that it's okay to fail, right? It's okay to experiment, and we're not going to bill you for every hour that you spend only in clinical practice, or we're not going to reimburse you for every hour that you spend only in clinical practice, but we're going to give you a little bit of admin time to experiment and explore. Okay, so the biggest gripe that I hear from physicians and clinicians is that I have to do this on top of everything else that I'm doing. Okay, and the moment you say that, that technology is doomed to be unsuccessful, right? It's doomed to rejection and failure because you've got a healthcare system where you spend 7.5 minutes with a patient, right? On average, 7.5 minutes with a patient, and your roster is full. You come in, you do your rounds, you see your patients, and you leave, and then you're on call at night. Okay, so where do you have the time to learn? So we need to structure that learning, that admin time, that downtime to think reflectively about this new technology. Okay, our last phase, routinization, is about freezing the change. And here I'm going to use a phrase that only an academic could construct. It's called adaptive routinization. Okay, and Gordon will recognize this phrase well because this came out of a 2-year study that we did with the Children's National Medical Center. Right? So for 2 years we observed, followed physicians before and after the implementation of a new clinical documentation system. Right? And our goal was to try and understand what makes a successful health information technology implementation process. And what we discovered is that at the end of the day, any successful implementation technology implementation requires that you put in motion a process of adaptive routinization where the technology itself is not viewed as immutable or fixed when it starts, but the technology and the work routines co-evolve. Okay? So what this means is you start your technology design by building in some flexibility for changes along the way. You allow users to see where and how the technology fits into their routines. The users are going to change their clinical routines just a little bit, but then they're going to say, hey, I want the technology to do X in this way, and I want it to do Y in this way. So the technology then adapts to that changed routine. We have a long academic paper on this, if anybody's interested in reading more about adaptive routinization. But this chart tries to capture the entire story in what I think is a succinct summary. Every technology enters a hospital or a healthcare setting with a narrative around it, right? And the narrative says, this is good because it addresses the triple aim. This is good because it improves patient safety, it improves efficiency, it improves quality of healthcare. The users see the technology and they say, hey, this is not improving my efficiency. This is not improving patient care. I used to look my patient in the eye and now I'm seeing him or her through a computer screen. The user says, I keep looking at this app and I see all this data, but I don't know what the heck to do with it. So the narrative as associated with the initial technology and the narrative as the users perceive it are two completely different things. And if that's the case, your technology is going to go into a negative cycle, right? And what we're trying to do over here is to put in place a virtuous cycle where you eventually see performance gains. Okay, so adaptive routinization is the process of putting in motion this virtuous cycle where we have a coevolution of structure, routines, and technology. And all of this is guided by changing the narrative around the technology. Okay? And the paper documents in grisly detail exactly what happened at Children's National Medical Center and exactly how these new symbolic expressions, these new narratives around the technology emerged, and what ended up at the end of 2 years was a very successful technology implementation.
What
Okay.
was the context of the study at Children's National Medical Center? What was being studied over?
So it was a clinical documentation system that was introduced, fundamentally an EHR system. And what we studied was the effect of that on two specific routines, the rounds routine and the expert consults routine. So how doctors, clinicians, and other residents and other people on the care routine, on the rounding routine were using the technology, and then how consultants who are coming in from outside to provide expert medical services were using it. Yeah. Okay, so what I've said really boils down to change in 3 very simple steps. You unfreeze any existing negative attitudes that people have about technologies. In marketing, we call it creating the felt need, right? So people are coming to the table saying, I really want this stuff. I need it. I can't live without it. Then you move, you introduce the change, and then finally you refreeze by rewarding the new behavior. And we could spend a lot of time talking about what specific incentives we might use to reward the new behavior. Suffice it to say that the jury is still out on financial incentives. It's not clear whether financial incentives could really motivate behavior change in the long run, because there's a phenomenon called crowding out effect, right? Where extrinsic motivation, the financial incentive, crowds out your intrinsic motivation, right? Your intrinsic motivation to serve people better or to get healthy, or whatever your intrinsic motivation might be. Okay, so let me wrap up in a couple of minutes. I think I'm eating into Albert's time now. I've talked about sort of overcoming the adoption and use barrier, but I haven't spent a lot of time on integration. I think in many talks this morning, we've heard bits and pieces of this effective integration piece. So I want to underscore one simple point, that mobile technologies and telehealth come within a broader ecosystem, right? And the broader ecosystem is the technology, the organization, and the environment. So we need to worry about standards and interoperability. We need to look at existing workflows. And to me, this is the most critical piece that often derails new technology implementations. That if we don't understand, document, and change existing workflows even prior to the introduction of the new technology, you're almost guaranteed that adoption is not going to be successful, and use is definitely not going to be observed. All right, so I promised that I would end with some promising new strategies for adoption and diffusion, and Kenyan's already mentioned a couple of them, so I mentioned what I was going to talk about, so I'll just highlight what we're doing with the diasocial application. Social influence can be a powerful mechanism for behavior change, so let's not think of these as technologies that are used by individuals, but let's think of them as technologies that are used by groups. And if we can put in place a process of contagion, right, we can set in motion a virtuous cycle where we have the network effects and groups persuade each other. And we've seen a lot of this in all kinds of health and wellness activities, from stopping smoking, from Alcoholics Anonymous to Buddies for Exercise. So the same idea. And this chart at the back here is from Christakis and Fowler's famous obesity study. I don't know if you've seen this, but it shows the social networks and how obesity is contagious, depending on whether you hang out with thin friends or fat friends. And then towards personalization, that is, let's think about a new paradigm shift in the design of mobile health applications. Let's not have the one-size-fits-all model, but rather look at motivational, personality, and other characteristics that might moderate the effectiveness of these health apps for individuals. Okay, so in my last 2 slides, and I'll share these with you, I have a very quick strategy checklist to sort of summarize the headlines from what I presented. Some of it was conceptual in nature, but it's all grounded in very real empirical research and proven best practices. So prerequisites, some questions that you need to answer. Does the technology create value? Has that value been quantified? Is it usable? Is it interoperable? Does it fit with the workflow? And if not, what needs to change? Okay, so these are the pre-rollout questions, if you will. And then the adoption, learning, and routinization questions. Is the marketing message clear? Does it highlight the relevant attributes? Remember I talked about relative advantage, compatibility, and complexity. Does it clarify the WIFM questions? What's in it for me questions, right? That's critical to answer. Have the opinion leaders been identified? Is the training and support adequate? Is the technology design malleable? So you can get that adaptive routinization process undergoing. And then what incentives can I effectively use to motivate the change? So I'll stop here and see if there are any questions or anything that we need to discuss further. Yeah.
What was the narrative originally at Children's, and then what was it? What was the new narrative?
So the narrative when the technology was introduced, coming from the managers, was that this was a technology that's going to improve efficiency, it's going to improve patient safety, and it's going to improve quality of care. The technology hit the road, and the clinicians immediately observed a reduction in their efficiency, right, because they were going up the learning curve. They immediately saw some problems with patient safety because residents were copying and pasting clinical notes from prior encounters just to fill in that field. So they were really not documenting what was happening with the patient now, but saying, okay, let me just copy. They were fighting over cows or computers on wheels as they went about their rounding routines. So very quickly, the reality was very different from the original symbolic expressions or narrative around the technology. Then the residents started using it, and a few innovative residents identified a new set of value propositions for the technology. Okay, specifically, they started thinking about this as an outstanding training tool because this is an academic medical center, right? And they discovered that everything that was being documented in the clinical documentation system, they could go back and review later on, and they would get some really nice insights. So that was a new piece of the narrative that was coming out. And then users started discovering different ways in which the data displays would make more sense to them. So almost like they asked for these dashboards on every patient, saying, okay, now when I'm going through my running routine, I want the previous episodes data pulled up and shown in a red, yellow, green format. Right? So that was again an innovation that they thought about. We changed the narrative. It says, okay, now I can improve the quality of my care because I immediately know how sick this patient is or whether he or she is getting better or not.
Okay, no, that's great. Yeah.
Okay? Yeah.
You talked about admin time. That was a big issue with some of our physicians trying to put these programs together because while the dean of the School of Medicine lacked the knowledge of telemedicine, the physicians were also very hesitant because they knew that if they took time away from admin, their regular stuff, their RDU counts would go down, which means that there's less. So basically, they're still kind of scared to do that because they don't want the dean coming down on them by saying you're taking away from this to do this, and now you're not getting any reimbursement for it. So.
Yeah, I mean, there's a 30-year-old academic article which says, title of it is On the Folly of Rewarding A While Hoping for B, right? I mean, that summarizes it, if you want people to use it, you have to give them the time to learn it. And if they're being rewarded for how many RVUs they generate, then that's it.
That's the thing with new technology or new things you're trying to implement. There's going to be initial ramp time in your learning curve, and if you're already maxed out in your learning, there needs to be a message or buy-in saying, okay, I need to spend extra time here because I do buy in and see that over longer run, I'm going to see efficiency, I'm going to see reduction in my patients because I will not be seeing redundant, non-critical patients, that I can focus on my chronic patients more, and other people, like my nurse practitioners and nurses, can take care of telemedicine and be able to take care of my other routine care.
And that's really a very valid point, because if you go back to this idea of relative advantage, right, you have to be able to articulate that to say that, look, this is useful to spend the time learning it because it's going to do A, B, and C for you. Allow you to focus on patients who are sicker, or in the long run, produce some efficiency gains for you, whatever the relative advantage might be. I think very often we sort of say, if you offer it, they will accept it, right?
If you build it, they will come.
If you build it, they will come. And if we don't spend enough time really thinking through, well, what exactly is the way in which, and marketers do this all the time. And it's, it's not rocket science, but we don't use it enough in our technology rollouts.
So do you suggest we bring in early adopters initially to the organization to help them design a system so they can adopt it, and then they can be the case use for others?
Exactly. So, these super users, we call them, opinion leaders, whatever term you want to use, they are the most powerful agents of change. Because they are trusted sources of information. They have the same type of challenges as any new practitioner who is looking to adopt does. And they really have the in the trenches experience, which is significantly more powerful in selling the technology than some administrator.
So the EHRs in general, do we give them a grade?
C minus. Yeah.
So
In my class, they would get a failing grade.
is there reason for hope, or once the system, they have no choice at some point. They to use the system, so do you have to go back and then
I don't think
recreate it? Just like you said, Microsoft, I might use 15% of Microsoft Office.
Yeah.
But nobody's getting me to go back in and learn the other parts.
Yeah.
Right?
Yeah, I don't think we'll get to a point where we'll rip and replace the existing EHR systems that have already gone in, right? I think what we'll see is, some usability tack-ons, if you will, right? So perhaps user interfaces that would sit on top of the existing complicated user interfaces and hide a lot of the complexity, hide some of the detail from the day-to-day user. But I don't think we'll see a significant rip and replace. And in some ways, it's no different from what we've seen with technology in any other sector. Right? The first set of systems that came out were really pretty clunky, but nobody had the money to completely replace them. And the legacy problem is starting to exist in healthcare as well. These bad
Let's hang it to the next phase, because like I say, you're not going to rip them out. You got to figure out how to.
Then you start putting together the APIs and the bridges and everything that will allow data to be transferred from here to there, right?
Yeah.
But fundamentally, the underlying technology remains the same. Yeah.
So I'd heard it said that the EHRs have created the fastest growing medical specialty, EHR scribes.
Yeah, absolutely. And that is true because, many physicians will not touch it, and they would much rather their medical assistants or, nurse practitioners or somebody else.
That's great cottage industry for undergraduates.
Yeah. Or, now, of course, voice recognition, the voice technologies are getting a little bit more sophisticated too, but not quite there yet, yeah.
That means the doctor still has to.
Yeah, I know. Yes.
One word I was thinking of as you were going through the slides is transition. Of going from the existing technology to the new technology.
Yeah.
The transition has to be very fine-tuned, because if you don't do it in the correct way, quote unquote, it could turn everything upside down.
Yeah, and we often refer to that as kind of the implementation strategy, right? So whether you want to do a parallel implementation or a phased implementation or a pilot or a direct cutover, cold turkey, those are important questions.
Right.
And your point is well taken. You have to weigh the costs and risks of doing it one way or another. But for most of these systems that we're discussing today, mobile and telehealth, they are not complete substitutes, right? Either they're new, like mobile health, which didn't exist before, or telehealth, you always have the fallback of saying, okay, this is not going to work, we'll do traditional face-to-face consultation. Okay, very good. I think it's time for a break. Thank you. What time do we have, Kenyon?
Let's think about